afternoon. I'm Dr. Grenier, and today I want to make a quick video that's a lit review on how forces are managed in dental implants. So we're just going to talk today about how these forces can be managed, which again can really make or break these incredibly complicated prosthetics. And I'm going to try to break down this simple concept into terms that, at least a mental model that's easy to understand. So forces in the masticatory system are generated by the muscles of mastication, the masseter, the temporalis, medial pterygoid. And these powerful forces are transmitted to the mandible, which creates this incredibly dynamic environment where the mandible transmits it to the implants, to the prosthetics, and then finally and eventually the maxillary arch. And if you can understand how these forces are managed, it can go a long way to predictably doing implants. And just to give people an idea of how complicated this is, even the muscles of mastication can cause some deformation of the mandible. It's roughly a third of a millimeter, but on some folks, it can be significantly more, especially people with thinner jaws, especially women with thinner jaws, which may not be bruxers, can exhibit significant deformation. And this isn't just a problem for full arch cases. If you're doing posterior bridges, ceramic zirconia bridges, you may see failures of these repeatedly that can be really baffling, but this could be the result. Now, conventionally, it's thought that this is a medial movement of the two halves of the jaw. The medial pterygoid causes internal rotation, which the lower teeth, mandibular teeth, actually are tilted slightly lingually, which can brace against this type of motion. But, all people really have to do is if you just squeeze a little bit, just like this, and bite together, you can feel that the occlusion on the posterior teeth shifts lingually just a little bit. And it's very easy to tell a clear difference between the two. And conventionally, and this has stood the test of time, this kind of prosthetic of putting implants anterior to the mental foramen. And this is an idea put forward. Mish advocates for it, Resnick. It's stood the test of time. This was the original way to do these, where you 5 implants. And one of the explanations for this is the anterior mandible doesn't flex as much as the posterior. So this is a safe area to work with. However, it does still flex. The mandibular symphysis will flex significantly, although even axial implants seem to work very well on the mandible, although they do fracture more. So the evidence is that there may be some issues with rigid prosthetics. Again, they do fracture more, but they can still be successful. And the key is to try to determine who it will be problematic on, but lit is still forthcoming on this type of thing. So, and it's not just the movement of the mandible. It's not just a simple axial opening and closing. The mandible generally arcs closed and in the forward direction, either for protrusion or lateral protrusion. So this type of motion, as you move forward, creates an equal and opposite effect on the maxilla. And this becomes very important when we talk about implant angulation and the overall types of forces that are put on a full arch fixed prosthetic or denture, or really whatever it is. And there are some huge differences in the types of bone and the quality of the mandible versus the maxilla. The maxilla does not move. It's softer bone, type 3, type 4, type 4 being similar to styrofoam, has an excellent blood supply. And this creates a different environment for the implants that are in the maxilla. That's why you often need 6 implants for an overdenture versus 2 in the mandible. And in the mandible, it's a U-shaped bone. It's the only bone in the skull that actually moves, and it is what dynamically loads the rest of the system. Now, the idea, and we've already discussed this, where the muscles of mastication load the mandible, which simultaneously loads the implants, the maxillary prosthetic, the mandibular prosthetic, and eventually the maxilla. So everything is loaded together. It must be taken into consideration. And the goal is to broadly distribute all the forces in this very complicated system. So, yeah, muscles, mandible, implants, and then finally the maxilla. And the idea is to create a bridge, and it's a bridge on a flexible foundation. It sort of floats, and any overuse of any abutment or prosthetic is going to almost certainly cause problems. Now, how do we determine how things are going? Well, one way is a predictive model called von Mises stress analysis, which is essentially a weighted average of every type of motion in a three-dimensional space, how much stress that given prosthetic or whatever you're examining is actually undergoing. And when you talk about stress, you also talk about strain. In bone strain, we talk about microstrain units, so 0.3% deformation. Any more than that repeatedly is going to cause damage and bone loss, cratering, and stuff like that. And it's got to be repeated because when you place an implant, you're doing much more than this, so it can recover. But if this is done repeatedly, you're going to have problems. So there is a window where it can tolerate certain amounts of microstrain. Every time you apply some stress, there may be some strain in that area. And it's given by this formula where your stress, the amount of force you're putting, is going to dictate, is going to yield a little bit of strain. And that's based by the Young's modulus, which is essentially the flexibility of the substance. So something like the mandible, which is very high quality, type 1 or type 2 bone, very stiff, is going to yield less. So you're going to have less microstrain with an equal amount of stress on the maxilla, which may have type 4, very soft bone. It's going to move more. So this is essentially you're dealing with a completely different environment, which is why we try to offset this by placing larger implants with more surface area, because that's going to better distribute this stress. And again, the idea is to broadly distribute the load. So no one area is going to be overstressed. And this becomes incredibly important, especially as we talk about cantilevers and management of cantilevers. Now, there's types of motion and forces that are much better tolerated by bone. Compression, as we all know, is much better tolerated. And anytime you have compression, you're going to also have tension. If you have compression, if you're actually compressing an implant straight down the long axis, you're going to have some tension on the other side of the threads, which they are less resistant to. And both of those are more favorable. The least favorable are going to be bending, like a teeter-totter, or shearing, like a sliding type motion. And both of those, once again, become very common in cantilever situations. Now, and this is commonly cited, we all know natural teeth can tolerate a significant amount of movement due to the PDL, 100 microns being the thickness of a human hair, but implants essentially don't move or resist any type of movement. And prosthetic screws, MUAs, multi-unit abutments, and attachments on them can tolerate more movement than that, but it's may certainly lead to problems if it's done repeatedly. And when we talk about cantilevers, these exist in single implants as well. So when you apply a load off axis, what you're doing is putting a handle on that load. So it's not just that you're creating compressive stress, you're also creating rotational stress on that implant in multiple different directions. And that is going to triple or quadruple the amount of forces. So you're going to have a lot of issues with this type of thing, especially for single units. If they're splinted, you can get away with this, but these can be very problematic for single units. And that is because exactly what I just said, where you're creating an environment where you may have certain forces on that implant where it's spinning or twisting or rotating or pushing on an implant or the prosthetic in ways that are incredibly unfavorable to it. So again, the only thing it really does well is compression, and creating anything else is generally going to be detrimental. Now, often what happens in these situations is the first thing that can fail is the screw. Now, how screws work in implants and everywhere is they act like a spring. So the screw is placed in and tightened to a given amount. And that actually stretches the screw slightly. And even if there's a slight rocking motion, whatever it is, force is applied, it's going to maintain that clamping force. However, it can begin to lose this. And there's an optimal torque. If you over torque it, it may stretch too much, and you may actually begin to lose your preload, regardless of what the rotational torque actually was. So and when they loosen, how that happens, it's generally a continued rocking motion, like over and over, and that will begin to stretch the screw ever so slightly, and you can actually have some wearing of that screw on the side or the sides of the implant, and begins to fret, begins to wear, begins to actually rotate its way out. So it's best policy, if this happens, to not just tighten it back down, because you're probably not getting the preload that you think you are, but to actually replace the whole screw, as well as fixing whatever occlusal issue you may have had. So there are some themes on what implant. There's really no surprise. It's very logical. It's going to be the implant in the back, the posterior implant. It's not just along the whole implant, specifically located on the crestal bone. So in situations, even in soft bone, that's going to essentially raise up the axis of rotation within that bone. And again, you'll have problems at the crestal bone. And, you see this again and again. That's where the stress is. That's where it's going to break. That's the area of greatest problem. And the question is, axial versus angled implants. Well, the conventional wisdom is, if you can place axial implants, place axial implants, but very frequently axial or angled implants can be done very, very successfully. And we've all heard of, why do you do it? Well, the idea is that you can place a slightly larger implant or a significantly larger implant, and you can place it hugging whatever anatomical thing you're trying to avoid, either in the mental foramen or along the premaxilla, the sinus. And this allows it to utilize the maximum amount of bone. It seems to do very well. And the idea is this increases the AP spread. AP spread being measured from the back of the distal implant to the midline of the front implant. And there's some conventional wisdom of how far you can actually go back, whether it's studies say 8 millimeters, 10 millimeters, 1.5 times the AP spread. There's several figures out there. But the idea is that you're better off reducing that cantilever. Less of a cantilever is better. So if you have the option of reducing it by angling the implant versus having a longer cantilever and keeping it axial, it's actually biomechanically based on von Mises stresses to actually just angle that implant and reduce your cantilever. And you see it in building all the time in engineering, where in some cases, by angling your abutments, you can still, in a rigid splinted structure, you can still distribute forces. And 30 degrees are often considered the more ideal MUA angle than 45. They even come in 60. And this could be an equilateral triangle. At least one half of it is going to be a 30, 60, 90. So there's a geometric reason that this lines up very nicely. And this also lines up very nicely with lit. Certain lit recommends 8 millimeters as your maximum abutment if you assume a 12 millimeter crown height space, a 30 mil is going to give those forces beautifully lined up like this, right through the distal part of the occlusion, which seems to line up very nicely intuitively, makes sense intuitively, and seems to geometrically add up. If you do a 45, you could do a 1-to-1, so you could do that would line up through the distal, and that would allow you a 15 millimeter cantilever, which is on the higher end of what's actually recommended out there. Now, all-on-4's been around a long time. They are the innovation. It's very simple. 2 implants in the anterior, 2 in the posterior, candid at a 30 or 45, and this allows them to engage high-quality bone, and these seem to be done quite predictably. And again, this steep angle does seem to work very well with, and then by minimizing the cantilever, it again seems to be incredibly effective. Now, again, axial may be more simple, more ideal, but again, one of the reasons why these could work so well is by angling the implant through the distal surface of it then you're actually lining up the implant axial, so it's lined directly up with certain types of forces. Although axial loading, it may not, you would rather have it directly underneath. If you're doing an anterior and forward type motion, like on the maxilla, that implant actually may be lined up very nicely to receive those types of forces. And furthermore, it's splinted with several others. So really, what doesn't work in one implant seems to work well when you have multiple splinted together. Of course, adding more implants does, at least with stress analysis, it seems to improve. Turning an all-on-4 into an all-on-5, adding a single anterior implant improves the stress distribution. And the idea is, you have a slightly longer AP spread, less of a cantilever, divides up the load better, extra support, more redundancy, possibly if you lose an implant. So something like this is a beautiful result. And remember, whenever we're talking about cantilevers, you can't eliminate them because there's always a vertical crown cantilever, crown height space, that is going to cause detrimental effects. And when an all-on has a certain height, they say you can go down to 9 millimeters for monolithic zirconia, but that's on the absolute low end. Safely, you're going to have to give yourself a margin of error and shoot for 12 to even 15. This is a significant amount of a cantilever because the implants are you're really only looking at a 1-to-1 crown height ratio with an all-on to begin with. So there's already a significant cantilever. So splinting it is already necessary. And this is a beautiful diagram here that shows that by changing the angle a little bit, you actually do lower the AP spread or further distalize the exit point. And, this can certainly improve how things actually come together, especially if you're going from an axial view to 30 degrees or even 45. Now, one thing to keep in mind, and I think this is very important, is when you plan an all-on X, a prosthetic, the amount of residual bone that you have to work with can change significantly because it's necessary to hide that line. And somebody like me, if I needed an all-on, you would have to remove 3 to 4 millimeters above that, my Duchenne smile, and you'd have to take that far back as well, which is going to greatly reduce the amount of bone I have available. So I may not be able to receive axial implants, and if you try, it may be very hard to hide that transition line. So somebody like that, even though you may have ample bone, after the all-on X is prepared, it may be very difficult. So it's important to consider these kinds of things, do a digital smile design, and figure out how much bone needs to actually be reduced before as you begin to prepare this. And this is a bone reduction guide to give people an idea of how much may need to be reduced. If this is how much needs to be reduced to hide the smile transition, this is 4 to 5 millimeters. This is going to change potentially the angle of the implants. If you do axial, the tilt of your MUA, and is really necessary to consider because it may completely change the placement and the exit point of your implants. Now, the common rule often cited is 1.5 times the AP spread, but again, lit is mixed. There's some that say 10 millimeters, even 8 millimeters maximum of cantilever, but the point really is the less of a cantilever you have, the better. Everyone seems to agree that less is better. There's many people that give maximum values, but there's no minimum. You really less is better. And the practical design is to, really, I think a practical consideration is to line your distal implant through the back, the posterior contact point. And another issue that you sometimes run into, because actually maybe a minimum, is there is a recommended cross-sectional area. And if we're talking about printed materials, it's actually 25 millimeters squared, which is huge. That's very long. It's 5 millimeters by 5 millimeters, or 4 millimeters by 6 millimeters. So this gets very large very quickly, especially if it's going around an MUA, because the MUA already has some surface area. So 16 millimeters is significant. And if you're doing something like a pterygoid, that means it needs to have 16 millimeters all the way around the outside of that, which in certain areas can be quite difficult. If it's in the bulk of the prosthetic, this usually is not a problem, but this is a cause for failures and another reason why bone reduction is incredibly important. Now, there's many alternatives to this. Really, the big three are either grafting, doing sinus lifts, but this is going to greatly increase the treatment time. And there's also remote anchorage options. And there's a whole protocol on this, pterygoid and zygomatic implants. These do have their own prosthetic indications. When you think about forces, these are also very angled implants. Zygomatic especially may only engage 10 to 15 millimeters bone, but they're 50 millimeter long implants. So there's going to be a little bit of flexibility there, which can be problematic in certain indications, in certain cases. But again, both of the lit on both of these seems to be very good. Either way, hope people like this. Please reply in the comments if there's any questions. All right. Thank you.